We welcome you all to Talk the Talk. My name is Janine Stiene.
And I'm Toni-Ann and Antoniato,
the masters of myofunctional therapy.
Together we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We are honored and excited to welcome Dr. Nora Ghodousi-Zaghi to this episode of Talk the Talk, joining us from the Breathe Institute from California. Dr. Nora Ghodousi-Zaghi is a board-certified pediatric dentist specializing in functional dentistry, including airway, sleep, oral health, and oral facial development. Thank you, Dr. Nora Ghodousi-Zaghi, for joining us today. We're so honored to have you with us.
Thank you guys for having me. I appreciate it. I'm looking forward to being here with you both.
Well, thank you. So we're going to get our questions started. So are you ready to be on the hot seat a little bit?
Oh, I love that. Let's do it.
Okay. So our first question is, Dr. Nora, can you explain to the listeners what the difference between a functional dentist is and an airway-centric dentist?
Yeah. So what functional dentistry is comprised of, it's a few different moving parts. And what we focus on is really the root causes of oral disease. And what we try to aim to work with doing is just focusing on the patient as an individual to develop an individualized plan of care. So this emphasizes prevention of oral disease, such as the oral microbiome and how it connects to the whole body, as well as the management and treatment of sleep disordered breathing and diet and nutrition. That all plays a huge part in this. And we also aim to be non-toxic, or to be have the least available toxicity in our treatments with our materials when we treat dental issues. And I really promote an all body focused approach to dental care, and in recognizing that oral health care is just one part of the puzzle, and that the mouth reflects overall oral health. When we talk about airway-centric dentistry, what that means and what it's comprised of is the airway. So what is the airway? So the airway is a channel of breath. And that breath is when we take the air in, it begins in the nose, and then it goes through the back of the throat. And that lies in the back of the throat would be, until it reaches the lungs, is the three pharyngeal walls and the back of the tongue. So various issues can cause an issue in breathing. And that could begin all the way in the nose, where there could be some sort of obstruction, or the tongue can cause issues, or it could be somewhere in the back of the throat, such as the tonsils, the adenoids, the soft palate, and etc. So what airway-centric dentistry does is, when we look at the child, we look at the child's structure to see how it supports their breathing. Then we look at their function, and then we look at their behavior of the child and see how it pertains to their sleep and their breathing.
Are all airway-centric dentists also functional dentists?
I don't believe so. I think it's really functional dentistry, airway-centric dentistry is really nuanced. Mm-hmm. It requires a lot of continuing education and a really deep understanding of the child as a whole, and the airway, breathing, sleep, structure, how to change structure to better support sleep and breathing, and making accurate diagnoses. And what functional dentistry, some functional dentists could be more supported in the restorative side of dentistry, and whereas some dentists do restorative as well as airway, as well as growth and development, and ankyloglossy and so on. So it's not one or the other; it could be both, but not everybody that does functional dentistry does do sleep and breathing.
Okay. Got it. I'm going to add to one more question, if you don't mind. Is there an age difference for which a functional dentist would want to see a child for the first time versus an airway-centric dentist? Is that age still around the same?
Well, that's a really good question. And I think it really relies on the practitioner and their level of training. So some functional dentists definitely can see the earliest of patients, which would be infants. And it's a beautiful, beautiful area to treat, and such lovely families to be able to see them so early on and it's great to be able to develop that relationship and that connection early, and to help diagnose early if there are issues, develop appropriate treatment plans for them. But some functional dentists don't see children. They might be more focused on older children or adults. And in airway and breathing, you can start seeing kids early, very early, like infancy and beyond. And sometimes I get the question, what do you do? And we'll talk about that potentially a little bit more throughout our talk, but you could see them very early, even in infancy. And if dentists feel comfortable with that, and some dentists might want to see them a little bit later just due to comfort and training.
So airway-centric dentists are, in a lot of ways, doing things proactively versus reactively. If I had to sum it up in terms for our listeners, for them to understand how that varies. Is that accurate in what I'm saying?
I love your analogy, and I'm going to use it in the future.
Well, I am glad to hear that. See, we'll always be resonating. Love it.
We talk about airway and sleeping for the pediatric population. What does sometimes sleep disturbed breathing look like in the pediatric population? Because a lot of the times we come across, well, they don't snore, and we try to educate that it's not just about the snoring. So what would you share in terms of what that looks like in the pediatric population?
That's a really, really good question. And you also probably come across patients that say, well, it's cute, they just snore a little bit sometimes, or their mouth's open just a little bit. But what I try to explain to families is that sleep disordered breathing is a progression. And one of the first signs is just looking at the child and seeing how they're breathing in normal state of being and how they're breathing at night. And one of the first signs, and often we look at it as a red flag, is looking at a child in rest and just seeing their lips apart. So we're looking at that, and that's called mouth breathing. And what we want to do is we want to rely on the nose to secure the breath rather than the mouth. And we're noticing that more children, often than not, are actually mouth breathing rather than nasal breathing. And why is this a problem? Well, you might see cavities due to the increased acidity in the mouth, or you might see in younger children lots of drooling when they're younger, or a dry mouth. This is concerning, because this affects the oral microbiome, it affects the gums, it affects the teeth, it causes inflammation. And also, what is in our throat when we're breathing through our mouth? It's our tonsils, right? So then we see these children, we open their mouths and they have these big, large inflamed tonsils, and that's just inflammation. Because the nose hairs, what they do is they filter. That's what their job is. They filter the viruses and bacteria that's in the air to help keep us healthy. But when we breathe from our mouths, we're breathing all the viruses and bacteria and air straight into the back of our throats. And then we get inflammation of the tonsils, or tonsillitis. And that can cause other issues as the tonsils get larger. The progression, like I was leading to, such as gasping, snoring, and other issues as well. So how can affect, and back to your question, what does it look like in their regular day-to-day lives? We might see kids that appear to be hyperactive because they're not getting into that deep sleep that we want them to get into. They're waking up frequently. Or we might see chronic fatigue, tiredness, kids that aren't doing well in school. It's concerning because then it can also get misdiagnosed by other practitioners, such as ADHD and other, they might put them on medications for this, where really it's masked as a sleep issue, sleep disordered breathing issue. And what functional dentists do is get to the root cause to understand, what is sleep like? What is the breathing like during the day and night? And what can we do to help resolve it?
Is every patient that has an open mouth posture necessarily mouth breathing? And if so, or if not, how can we determine that, or how can we make that determination?
That's a really, really, really good question. So one of the first things I do when I see a kid, and I saw one this morning, 18 months old, is they have that open mouth posture. Take a mirror, take a big regular mirror that you look in, just put it under the nose when they're just hanging out with you. Look to see, is that mirror fogging up? Is it fogging up bilaterally where both sides of the nostrils are? Is there an obstruction on one side of the nostril? Look to see what's happening there. You might see that both sides of the nostrils, where the nostrils lie on that mirror, are fogging up bilaterally normally. That means they have open mouth posture, but they're breathing from their nose. Or you might see that the child, there's no fogging at the mirror. That shows that they are mouth breathing. We consider mouth breathing to be pathologic when it's more than 10% of the time. Okay. And so that's just how we view how we view mouth breathing.
Okay. Interesting. Very interesting. Okay. So moving on, how can tethered oral tissues impact sleep for children?
Yeah, that's a really great question. So when we look at the tongue, what we see is that it's enclosed in our mouths. And like I mentioned, the airway, it goes through the back of our throat. So when we're asleep, all the muscles in our body relax, okay? Including the 16 muscles of our tongue. So if the tongue is tied down, either from the front of the tongue, and I have my little puppet here, so let's say hello to him.
I love it. I was hoping those guys had a function.
Yes, they do.
Okay. You're multi-talented, Dr. Zaghi.
We've got to keep it fun. Okay. So the tongue could be tied in the front of the tongue or in the back of the tongue. And when we're asleep, all the muscles in our body relax, including the 16 muscles of the tongue. So what can happen is that tongue, if it's not toned enough to stay up on the roof of the mouth, or if it's tied down, can easily fall back into the airway, which can result in waking the child up because it's causing some sort of choking feeling, or it can result in other things such as grinding or low tongue posture, mouth breathing, or gasping for air as well.
Okay, wonderful. And aside from the tethered oral tissues, we also know that the palate can play a role. So how can a patient or a child who has a more narrow, high palate, how could they possibly be therefore suffering from some sleep-disturbed breathing?
So the palate, so form follows function, right? So we look at the tongue like a car and the mouth like a garage, right? If the tongue doesn't fit in the mouth, or the car doesn't fit in the garage, what happens is that you're going to leave the mouth open. So that's when kids have issues with structure. They have epigenetically small mouths. They might have been premature, or they might have syndromes, prematurity syndrome. Certain syndromes, they might lead to high and narrow palates, right? So what happens is that the tongue, maybe if it's might or might not be tied, will remain down because that garage is just too small. The car can't fit in it, right? So that can impact the child's sleep or their breathing because the tongue will more easily fall back because it just can't fit well. So what we need to do more often than not is make some space, create space through growth and development appliances and through therapy to help create space for the car to fit in the garage or for the tongue to fit in the palate. And what we find is that children start breathing better. And it's incredible because what we see is that the floor of the nose is the roof of the mouth. And as soon as we start opening up the maxilla, she's laughing because she's
I'm literally hearing you talk and I can hear like my words because I say the exact same thing. There's no way to spruce it up. I know.
It's great. I love it. So the floor of the nose is the roof of the mouth. So as we create more space in the maxilla or the roof of the mouth where the palate is and where the tongue is supposed to lie, we also see that it opens up the nose. So children breathe better, they sleep better. Their sleep disturbances decrease, snoring decreases. It's incredible.
Sometimes we're kind of juggling between someone who may be borderline for tonsil and adenoid removal versus at age where they want to expand. And we're kind of saying, well, maybe start with the expansion because that could be what's needed for that airway rather than the surgery of tonsils and adenoids. So we find that sometimes it's kind of like a juggle between the disciplines.
Yeah. And we're supporting that interaction as well, you know?
Yeah, and that's why multidisciplinary care is so important and crucial into developing that treatment plan as to what to do first in order to help support the child to get them on track, to get them breathing better. It's not about just doing one procedure or one simple fix for the child and saying, okay, you're going to be great now. It's more nuanced than that. It requires a team. It requires speech and language pathologists, sometimes IBCLCs. It requires myofunctional therapists at times. It might require OT. It might require the dentist or the ENT, sleep physicians. There's so many moving parts to making sure that the child's on the right track and helping support them on their journey to health and wellness. Yeah.
So if you are an airway centered, dentist, are you intervening with expansion earlier than a traditional orthodontist would typically intervene?
Yeah, so I focus on growth and development from birth and beyond. So I have different tools and interventions to help with creating that beautiful garage for the car to sit in. Help support, not just for aesthetic reasons, but to help support the structure. The child can sleep and breathe better. And there is so much that can be done early on, so much that we can help patients with. It blows my mind and makes my heart feel so full. Yeah.
Is there any benefit to that? I know many of our patients will come back from the ENT and say they have a deviated septum, and that septum cannot be addressed until at least 18 years of age. In a situation like that, would that palate expander create that space maybe in the interim in order to give them more room in their nasal cavity?
So deviated septums don't need to be treated that late. They're at all times. I mean, of course, there might be, it depends on, it's all case based, right?
Okay.
From my understanding, from working with my husband closely, who's an ear, nose, and throat physician and a sleep surgeon, we can do treatments or interventions more minimally invasive early on and to help supporting their structure so they could sleep and breathe better. If expansion is necessary and it can be done to help their sleep and breathing, we would do it as well. But of course, you're not going to be able to breathe from the nose if you can't breathe from the nose. If there's an obstruction there, whether it be deviated septum, enlarged turbinates, or nasal valve collapse, what be it, if you can't breathe from the nose, then there's not much that we can do to support you until you get that fixed.
And would the same thing hold true with jaw issues, whether an underbite or issues that makes that lower jaw more pronounced?
Yeah. So what we see here is when we see children with lower jaws more forward, we often see that they also have underdeveloped maxillas, so underdeveloped upper jaws. And like I mentioned before, is that these underdeveloped upper jaws can be due to maybe the tongue being too low, because the tongue is the driving force of growth for the premaxilla. If we cannot get the tongue up, then we potentially will have that underdevelopment of the midface, or not have that maxilla grow to where we need it to be. And other than underbites or having a lower jaw forward, what we find is retrognathic mandibles, or lower jaws that are too far back, also contribute to these sleep and breathing issues. So retrognathia, or lower jaws being back, are a big cause of apnea. And that, by helping stimulate the jaw growth and development of the jaws, we notice that children tend to sleep and breathe better.
That's really interesting. We always come up against that, especially in that population that either does not want to have their surgery done, but still needs to make gains, or just not of age to have jaw surgery or and move forward. We find the same issue with speech. The air is going to resonate in the space that is provided. So whether that's the nasal cavity or the oral cavity, the quality of their speech as well as the resonance of their speech will alter as well. So it's interesting how there's such an overlap between the two.
Mm-hmm. And to add to that, that's a big part of what we do with open bites. Mm-hmm. If the child has an open bite, either due to structure, like I mentioned before, thumb sucking, overuse of the pacifier, you all as speech therapists are not going to have a place for the tongue to sit in order to make the appropriate speech sounds. And correct me if I'm wrong, those might be L, D, T, N, S sounds. And we won't be able to support the patient to be able to have these appropriate speech sounds if we don't have the correct structure, if the bite remains open.
Mm-hmm. Makes sense.
Mm-hmm. And we talked about a lot with the malocclusion. One thing we didn't really touch on is the crossbite. How can that play a role in these patients?
So crossbites can be related to position, and it could also be related to oral habits. Position meaning if we're noticing, it could be related to how a child might be sleeping, either the one side versus the other side, pushing that lower jaw, because jaws are so malleable at young ages that we can essentially grow the jaws in different directions, but the ways that we're sleeping. In addition to our habits, and these habits that more often than not, I find to be the thumb sucking, the pacifier usage that helps it. If where you're placing your thumb might develop one side more than the other, leading to a crossbite. And a crossbite looking like this.
Mm-hmm.
Makes sense.
Yeah.
Yep. Okay.
Wow. Just when sleeping, I never really thought of that.
No, I never thought of that either. That's such an interesting way to what to consider as part of that jaw instability. For parents who are concerned about teeth grinding, what types of things or what kind of indications could teeth grinding actually be symptomatic of? Is it more than just wanting to have those nails screeching on a chalkboard, or is it more about something that they're benefiting as a result of the grinding?
Yeah. So teeth grinding is a phenomenon, and it's definitely multifactorial. Lots of things lead to teeth grinding. So between the ages of like 0 to 3, what we find is that our jaws are translating in order to get the teeth in the right place. It can, so different teeth are growing in at different times. So we're kind of translating our jaws and getting those teeth in the right space. So you might see teeth grinding as a result of that. And you also might see some non-nutritive sucking as well when they're sleeping, pulling that jaw and hearing that grinding as a result. Okay. When they get a little bit older, when all the teeth are in the right place and that the sucking has transitioned, I would say, what we notice is that children that grind have a statistically significant association with tongue ties. And what we found in our most recent research is that what happens is that our theory is that the tongue, since it's tied down, the entirety of the tongue can't remain up in the roof of the mouth, which we want the front and the back of the tongue to stay up and our lips to be closed and sealed when we're breathing at night. But if the back of the tongue or the front of the tongue is tied down, what happens is it's very easy for the tongue to go back into the airway. And we go into survival mode. We try to push our lower jaw forward to help push that tongue out of that airway, which results in that grinding. Okay, so that's a theory. Other reasons for this activity can include stress or other like airway issues, like enlarged tonsils as well, or issues breathing due to enlarged turbinates.
In a situation with an individual or child that is teeth grinding, and they go to the ENT and realize or told that their tonsils and adenoids are not significantly enlarged in order for intervention. Where do those patients wind up? Do they wind up doing a therapy regimen? Where do you typically see that with patients?
So first, I just take a full functional assessment of the child, and I look at them, and I look at a few different things. I look at diet, because food and dairy can also be related. I also look to see if there's an obstruction in the nose, and if the ENT is cleared, potentially not. I look to see what their regimen is at night. So are they rinsing their nose at night? What are they doing to help optimize nasal breathing? And I also tend to recommend saltwater rinses to help bring down the inflammation of the back of the throat. So these are all things that therapists can do to talk to their patients about, right?
Absolutely.
And also moms and dads listening can help do that at home too. So if you're thinking, oh, what could be the root cause? What can we do? Let's start there and then go from there. And then we can, what we have found is that research has showed that if we expand, the tonsils tend to shrink. And we've seen this in patients. Why? Because like I mentioned before, the floor of the nose is the roof of the mouth. So as we're increasing the ability to nasal breathe, you switch from mouth breathing to nasal breathing, and then those tonsils tend to shrink.
And that's really why we're seeing Myo is being recommended for sleep disordered breathing or patients with sleep disordered breathing.
Yes.
Because they're talking so much about developing that form and that function, but in the appropriate way. Or is it the form may not change much, but the function hopefully will.
Yes, absolutely. I agree. And I think myofunctional therapy needs to be a part of every orthodontic treatment plan, regardless of age. And if they're younger, it should be oral motor feeding therapy. And when they get older, it should be myofunctional therapy. And your therapist will help determine what's best for you based on how the child presents.
Absolutely.
Excellent.
What are some questions that a parent could prepare if they are coming up to their dental appointment for their child? What are some good questions that they could ask that could support, the knowledge of their pediatric dentist could support them with?
So I would ask questions how I would ask questions would include, what kind of products do you use in your practice? That might be important to some parents. And I would ask, do they do full functional assessments of the child? How do they view sleep and breathing in their practice? And have they done continuing education to help support children with sleep and breathing issues? Or if that's not a concern of theirs, how about if they're concerned about growth and development? Ask about their growth and development expertise. Do they have any experience treating kids that will need modifications in their growth and development? If they're noticing these epigenetically small jaws, or if they're noticing that their child might or might not have a restriction in the back of their tongue, does the dentist have experience treating kids like this, or have the knowledge or interest in learning more? Because a lot of dentists, I truly believe the dental profession, we're all doing the best that we can to help support our patients, but we need the support. We need the support of continuing education. We need the support of learning from our peers. And if they're in a collaborative group with speech and language pathologists such as yourself, or IBCLCs, or their supportive group with OTs that have this background and knowledge, they might not be able to support you. They might have a collaborative provider that would. And that's what I like. That's how I would envision many practices to look like, a collaborative team where multiple providers are available to help the children stay on track.
And from my understanding, ironically, Brazil does have a myofunctional therapist in every dental practitioner's office.
Oh my gosh.
I know. We're way behind. We're way behind over here in the States.
Yeah.
Clearly behind. However, I do, their big focus obviously is addressing the form as well as the function, or watching that function change as the form of their mouth changes.
Exactly, because crooked teeth are just a symptom. They're a symptom of something greater, and the something greater can be tethered oral tissues. It could be sleep and breathing issues. It could be diet and nutritional issues. It can be a lot of different things. So if we're able to get to the root cause of these things, to be able to help prevent them from occurring again, that's the ultimate goal. Yeah.
If you are a parent of a child that you think could potentially have a short freedom, or say they have no knowledge, is there something that a parent can do in order to assess for that? And then also, are there certain times that they should be doing that? So from our experience, if it's not affecting latching and they're not failure to thrive, then it doesn't really become a focus during infancy. And then if there's no issues with gastric reflux or digestion or sleep, then it kind of bypasses that as well. So then for us, the next time would be with a dentist, which ultimately could be years and years and years later. So is there a time frame or a time when a parent should be looking, or even therapists that should be looking routinely to see if there is a concern, especially if other providers either have not identified it or have chosen to say it's not an issue?
Or they don't notice it. Yes.
Yeah. I was trying for the I was trying to be the nice way to put it.
No, it's okay. It's okay. It happens. We dentists, we see, many dentists see many patients a day. So I always say, you don't know what you don't know, and you don't see what you don't see. So a dentist might not see something right now, but they might see it 6 months from now. So back to your question, I definitely think that a parent should be aware at birth, like you mentioned, when maybe there's ineffective feeds, the child is falling asleep at the breast, you notice that they're not able to drain the breasts effectively, or they're crying at the breast, very frustrated. That might be due to a tie also clicking. Can be a big sign as well. And that's when lactation consultants really play a big role into helping guide them in the next steps. Also, we see that as they get older, there might be issues with speech. And the speech is where we're noticing that they're not able to do the T's, D's, L's, and N's, or bringing up the back of the tongue to be able to say the K and G sounds, or connecting those sounds together. Potentially also rolling the R's might be hard as well. And then we're noticing with feeding, it might be difficult for them to chew and swallow, lateralize the tongue properly in order to get the bolus down. We're also noticing more picky eating. Kids are not interested in using or eating foods like, I've had some kids that don't like bananas when they have grade 4 tongue ties up at the front because they don't like the texture, because they can't get the whole banana back from the back of the throat. Yep. But we're also seeing that they don't like the harder to eat foods, and the harder to eat foods because they can't get that tongue back to be able to clean their teeth effectively right afterwards. That might be an issue. And we also notice dentists, these kids have a lot of cavities, caries, they have dental disease. And this is because they're also not able to clean the teeth effectively with their tongues, or between the two front teeth. When there's lip ties or labial restrictions, we see that there might be caries right between the two front teeth. And that's because the food tends to pocket, and it's difficult for them to clean it effectively. These are all signs that you as a parent might think, hey, maybe somebody didn't see it, but I'm noticing these correlationships or these associations. Maybe I should go to a specialist or somebody that has more experience in this. Or maybe when they're a little bit older, they might see, not children, but adults might see some neck and shoulder pain, full body pain. And that's because the tongue is connected to the deep front line, and the base of the tongue is actually the start of the deep front line. And that's the fascia system. And what we're noticing is that people, when they get these releases, they see these full body effects of release. And it's connected from the restriction that lies all beneath the tongue, and it can affect the entire rest of the body.
I can't say, excuse me, how refreshing it is to speak with a provider that all of the things that you're saying align so closely with how Toni-Ann and I run our trainings and our practices and treat our patients. It's wonderful to hear. I wish you weren't so far away from us, but it is nice to hear this. You could still go to the next one since I keep hijacking the interview. I'm sorry.
I wish that you guys were closer too.
We spoke a lot about the different providers that we collaborate with as speech pathologists, as pediatric dentists. But if you want to just sum up in terms of the other providers, what are you feeling is like that good, perfect team on a patient that is presenting with airway, sleep, anything like that?
Wow. I can list 20 different professions that are important, but not every patient is going to need all of these people. But I do believe that if I can give a shout out to all the amazing providers that have learned so much in the sleep and breathing and about sleep and breathing and the relationship to sleep and breathing and what they do for the whole body, which is a whole patient. And this includes anywhere from IBCLC, LC, oral motor feeding therapists, SLPs, nurses. We have dentists, we have physical therapists, craniosacral therapists, chiropractors, body workers. We have ENTs, sleep physicians, doctors, and psychologists, and sleep hygienists, because they might have these kids might have these issues, and we need to support them potentially with, maybe they have anxiety, they might need therapy until their sleep and breathing gets better. Because if they're not sleeping well, they're not breathing well, they're not going to feel well. And they need better ways to learn how to calm their body and to connect with somebody that understands the physiological connection to their emotional health. That's key too. So all of these wonderful professionals play a role. And it's just having a team of collaborative providers that understand the nuances into treating this patient population.
I think the big question is, when is the Breathe Institute going to come to New York?
Exactly. Yes. I think there needs to be an East Coast location.
Yes.
Oh gosh.
We have plenty of patients for you.
Yeah.
Seriously.
You guys are so kind. Well, luckily we have a database of amazing providers that have gone the extra mile to learn so much about this field. And and if as therapists you want to learn more, as a dentist you want to learn more, our courses are available. They teach online and in person, and it's a great way to learn more.
Yeah,
absolutely. Just piggybacking off of the last question, I have been seeing a lot lately that dentists are providing home sleep apnea kits. In lieu of referring their patients straight to the ENT for a sleep study. What do you feel in terms of the effectiveness of that? And do you feel that's a good approach to start with before going the other route?
That's a really good question. I think that polysomnographies, well, let's start with children. Polysomnographies are known to be like the gold standard for how to do a sleep test.
Okay.
But unfortunately, it's a very unnatural way of sleeping. So if you know what a polysomnography is, they take you to a sleep lab and they try to make it comfortable for you, and somebody's watching you and they're putting a bunch of electrodes all over your body and they're telling you, go to sleep.
Yeah, in the most natural way possible. Just,
It's not even like a nice, friendly hotel. So how are you and even yourself, think about yourself at a hotel. Are you sleeping in your natural state of being? And even if you're the most frequent flyer, it's always pretty tough to get you back into your normal environment. So we don't see them as being the best, most effective way. But I have seen some patients that come to me after the fact, and they've found some very fascinating fascinating results from their polysomnographies, and they've gotten some good answers from those. So there's definitely a place. But what I tell families is to just get your phone out and just take a video of your child sleeping and show it to your doctor. Does this look normal? Does this sound normal? See how they're sleeping. Are they sleeping on their side? Are they sleeping on their back? Is their mouth open? Is their mouth closed? How do they sound? Are they gasping, snoring, yearning for air? Are they sleeping on their face? Why are they sleeping that way? That's one way. And then there's also something called Snore Lab. It's an app that you can download on your phone. And for adults, what you do is you take this app, you put it on, and it counts to see how many sounds of snoring that you have throughout the evening. It's really interesting. Okay. Yeah. So you can just download it on your phone. And then back to your question where you asked about the in-home. So dentists prescribe these in-home sleep tests because they're much more, you go to your own house. So it's a much more natural way of sleeping. And it also takes into account the sleep disruptances as well. So you take that to your ENT and tell them, hey, this is what I found. and then they could explore more and see what the issues might be at hand.
Which Toni-Ann can speak to firsthand because her daughter just had her tonsils and adenoids out last week.
Yes.
So she's
yes, but I had to do a lot of advocating on my end.
That's what I was just going to ask.
And tell us how is she doing?
She's doing okay. It's, it was definitely a pretty brutal 10 days recovery wise, but everything, went fine, and I already see huge changes in her sleep. Which was really her only symptom, which was why I kind of had to fight and advocate for why I felt she needed those out. And I already see big changes. So I'm looking forward to all the rest that will follow from here.
And I will add that I've seen families where they didn't know. And then over time they looked and they went to the pediatrician, and then they saw, oh my gosh, it's been 1 year and your child's only grown 1 inch in height. That's a huge red flag, because we have so many changes that happen in sleep that relate to hormones that are being released that allow your child to grow. Wow. And if you're not sleeping well or breathing well, then your child doesn't grow. So I'm interested to see how your child grows.
I have to measure her when I get home now.
Exactly. But how she thrives overall and her well-being afterwards. So congratulations to you.
Thank you.
To her.
I definitely think the hardest part for us is a patient just like Gianna, where we would refer her, Natalia, we would refer her to an ENT, but everything is not bad enough to intervene. And then at that point, is that where an airway-centric dentist could definitely be helpful in the sense of, okay, well then if they won't remove them, then let's try to make more space with expansion.
Yeah, I absolutely think that your dentist should be on your team, and just having like documentation, from your dentist that this is what your dentist saw, and this is what this video, my patient brought me this video. This is what I see. So these are just things that you can do to help advocate for yourself. The same. This is what my doctor sees.
Yeah, our area, it's still a lot of, do they get X amount of strep throat, X amount of ear infections, and we're still trying to kind of get past that textbook of a criteria, and including the whole body and recognizing what else it could be having a negative effect on.
It's like the pendulum swung the other way now. Nobody's taking them out. We just have to wait for it to swing the other way, and everybody is
happy in between.
Yes.
And like you said, Janine, minimally invasive options like expansion and myofunctional therapy, getting back to nasal breathing. Those are all really great ways to help support. To see, hey, maybe surgery won't be necessary. That's possible, and then going from there. Yeah.
All right, so we have one last question. I'll let you take it, Toni-Ann.
So in terms of myofunctional therapy, I know you already made comment that you feel like it should be on every single orthodontic plan, but how have you personally seen myofunctional therapy make a difference in the function and success of your patients?
Yeah, so I think like I said, myofunctional therapy should be a part of every dentist treatment plan when they're seeing these issues, whether it be mouth breathing, crooked teeth from a result of a functional issue like tongue thrusting, open bites, oral habits. And what I've seen specifically would be a multitude. What I do see is the connection that they build with the therapist and the dentist. That connection of trust is beautiful, because the child understands that you care about them and that you care about them getting better. That's a huge part, I think, in just overall supporting their health, because you want their child to become better. You want them to feel better, heal. And it's not just doing a procedure and making them having that bigger understanding that it's not just doing the procedure and not just doing one orthodontic intervention. It's about the whole body and supporting the soft tissue structures as well as the hard tissue structures. And I've seen my patients sleep better, breathe better, talk better. I've seen them get off of sucking their thumb and stop using the pacifier through different therapeutic techniques. And I've seen them be able to keep their tongue up on the roof of their mouth and try different foods and eat different things. And these are all such important ways of supporting children and also making them be able to thrive and do well in their daily doings, doing well in school. That's incredible. These are incredible ways to help improve, to help children just feel and breathe and do better.
Okay, so I told a little lie. I have one more question. So if we have a patient that's in need of myofunctional therapy, their tonsils are big, we can't see their adenoids, obviously. We make a referral, but they decide they're not going to take them out. Is that a cue to us that it's okay for us to work on nasal breathing, that the doctor is giving us the okay to say it's not an issue, they need to rely on their open mouth posture and mouth breathing? Is that kind of clue us in if the doctor is not willing to intervene?
Well, what I would do is just to make sure, I would do a nasal breathing 3-minute lip seal test to help just start by having them close their lips, seal their lips, whichever intervention the therapist deems is best for the child or for the adult, and see if they're able to breathe 3 minutes without any reason to take off the tape rather than talking. And I would make it a quiet 3 minutes. Either they can read a book, look at a movie, or you can talk about health and education. I like to do or health and education, things of that nature. And if they're able to do the 3-minute lip seal test and you have clearance from the ENT, then I would begin doing myofunctional therapy, because I definitely think that it would support them.
Okay. That's really good. Thank you so much. Toni-Ann, is there anything else you had questions about?
No, not at all.
This was so enjoyable. I thank you so much, or we thank you so much for taking time out of your busy day to speak with us. But I think the education that you provided not only supports Toni-Ann and I and opened our eyes to some things, but I think it will definitely be a benefit to our patients and their families. So thank you for coming with us today.
Well, thank you guys for inviting me. Thank you guys so much for what you both do to help advocate for the children in your communities and help support them. You both are so important to the children and people that you see and the families that you help heal. It's incredible, all the great work that you all do. So I appreciate being a part of this. It's an honor.
Thank you. And thank you for everything that the Breathe Institute does for patients and for SLPs and other providers through the education that you guys and the courses that you run. Those are all so amazing for the community.
I appreciate it.
Yeah. Well, you have an enjoyable rest of your day. Thank you so much for joining us.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk.
And stay tuned for more information about our newest venture, the Spot Pal, a tongue training appliance.